So we will discuss the paper in the reverse order. So let's begin with Dr. Grassi. Do you have any question about microaneurysm? By the time I have a question for you.
It's all clear.
So very, very interesting. So do you think that the OCT-A have a 100% possibility to detect it? So in a way that if you don't see anything in the OCT-A, you can eliminate that there is active microaneurysm, or still you think it's good when it works, but you cannot be sure 100% that it will show it?
Fluorescein angiography remains the gold standard of
Still.
the detect. Yes, yes. But OCT angiography is very useful to detect it, especially if the microaneurysm is localized at the posterior pole. Obviously, if the microaneurysm is in the periphery of retinal periphery, it is impossible for angio-CT reveal that.
Sure. So could we say that if you see it on the OCT-A, then the diagnosis is made, but if you don't see and you suspect that there is, you can do AFA to be sure that there is or there is not? That could be a strategy to do OCT-A
yes,
first?
Yes, I
AFA
think
if needed?
that.
Have you, yes?
I'm having an extra comment if we use
Sure.
the 12 by 12 scanning, which will be updated to our instruments. And if we'll have a composite photography for the OCT-A to the periphery, I think this might help for the peripheral lesions as well. But questionable if the patient fixation and the cooperation of the patient will help or not.
Sure.
According to
we have only line by 9 cube.
Yes, and it's very difficult.
Yes,
even.
yes.
For me, I use 6 by 6 mainly, 9 by 9 if I want to do the peripapillary region.
Most of the big microaneurysms are quite posterior.
Posterior
They are
pole,
not
yes,
so
inside
far,
the
so it
arcades.
should not be a problem. Yes, a question. If you have a question, please raise your hand so we give you a mic. Can we have the mic there?
Some microaneurysm may not be detected by FA or by OCT angiography, and ICG angiography can help us to detect some of this. In our experience, we had some cases detected only by ICG angiography.
Late phase of ICG. Have you tried this?
No, ICG no. For the microaneurysm, I no.
You are right.
It's not necessary.
Capillary microaneurysm that you have in diabetes are quite well detected by ICG late. So you know those who are exudating actually because the protein exudates, so they go with the ICG. That's a good comment.
But I think these are more retinal, not choroidal.
We are talking about retinal microaneurysm.
You know.
We are not talking about choroidal microaneurysm. But still with the ICG you can see it in the late phase. Other questions for Dr. Grassi? So we'll move to Dr. Hassan. Your presentation. Is there any question for Dr. Hassan about the corridor thickness and diabetic retinopathy?
Thanks God.
No, I have a question for you. So I have a few questions. Did you normalize your data for age and refractive error? Because we can imagine that age and refractive error could influence the detection or the...
Sure, I might skip that point, but it was written in the slide, but I skipped it for the time. The age group was from 45 to 65 years old, and those myopes and hypermetropes of more than -2 +2 were excluded from my study, and also glaucomatous and high IOPs might change the ganglion cell layer and comparably the choroidal thickness and the retinal thickness.
Jose, you have some comments on questions?
No, my problem with choroidal thickness has been always the fact that you are dealing with type 2 diabetic patients, mostly that have already blood pressure increases, abnormalities, they have advanced aging. I mean, the disease causes early aging, and therefore I always have very much difficulty in accepting choroidal changes as having any real meaning at this age and stage, because I don't think it will be regular. They would not have regular thickness. They will be not normally expected in anyone over 60 in a diabetic type 2, and I don't know, but again, I don't think we have the precision to look at choroidal vasculature with the present means to have these differences
Did you
clearly.
look to the blood pressure in particular?
Yeah, this I should have included in my study as well, the medical history of the patient, but there will be much more,
Normal.
to normalize the blood pressure and the hyperglycemia, as you mentioned in your speech, the state of the controlled blood sugar level, hyperglycemia may add as well for the increased thickness of the choroid.
And your working hypothesis is that diabetic retinopathy influenced the choroidal thickness, or your working hypothesis that choroidal thickness influenced diabetic retinopathy? What's your, or you don't know?
In my scope, I think that the choroidal thickness is correlated to the macular
correlated,
thickness.
but not causal.
It's the cause.
It's the cause.
Yes,
It's the cause.
because whenever there is thin choroid, this equals that there is a capillary non-perfusion, which equals to it's a vicious circle that goes.
At least it's contribute, let's say,
contribute.
because it could not be the only cause. I mean,
I think
probably.
it's diabetes is a complex.
Yeah. Any other, yes, comment,
Yeah,
question?
I just wanted to make one comment regarding, is this working? Yeah. Regarding the choroidal thickness in these types of systemic diseases. One difficulty with, because you were discussing a normative database, that's very challenging, because even in the same patient on the same day, you can have a certain amount of swinging. So a normative database would be very difficult to achieve. But we've recently in the software, we're allowing you to do something that I call choroidal vasculography, where you invert the structural data instead of the OCT-A data, because it's an isotropic scan, and you do an RPE-fit slab. And when you visualize that, you can see not only the thickness of the choroid, but the structure of the
morphology.
choroid, the morphology of the choroid. And I think in these types of systemic diseases, not only looking at the thickness, but looking at what is it that's changing in the thickness. Is it the hallux layer vessels? Is it the satelloid layer vessels? Is it the stroma? Where are these changes happening? But also looking at the branching pattern changes inside the choroid to see if there is, right now we don't know, but to see in the future if we can find some kind of recognizable pattern in there. Yeah?
Or to see the inside of the cave, as you showed in your very nice lecture yesterday.
Yeah, but that's currently just me playing around with data. That's not possible on the instrument.
But one point that you are making, I think is very important, is the fact that maybe a variable that's more worthy of measuring is the capability of the choroidal vessels to change within the same day.
Yes, exactly.
That would be much more meaningful than thickness alone.
Yes, I agree with you, and there are medications that you can actually use to test changes in the choroidal thickness. I mean, not to be childish about it, but simply give the patient Viagra, and 20 minutes later the choroidal thickness will change by about 15%, and you can actually see whether or not there is a significant
that could be a good test to start with.
Yeah, I don't think we'll have a problem finding volunteers.
There's no solution.
Very good. Thank you. Other comments or questions for Dr. Hassan? So we move to Professor Ophir. So you have very interesting data, and especially in tractional, the role of traction in diabetic macular edema. So any question from the floor on traction and how we should treat them to stimulate questions? So I have a question for you. So I find the most challenging part is that when you have an epiretinal membrane on the surface of the retina,
Is it tractional?
because you don't know how much it contributes to the decrease of vision. Some of this edema you treat, the thickness decrease by the treatment, but it's not fully normal, and you don't know if it's still worse to take the epiretinal membrane off or not. Do you have any special strategy to share when you decide that a membrane is contributing to the decrease of vision and when it's just here but it's not contributing to decrease of vision?
There are, first of all, we brought a paper in investigative ophthalmology maybe 4 years ago, and we called it AV membrane, which means the ERM is in continuation with the posterior hyaloid, the detached posterior hyaloid. And we showed by the video, is it the same membrane?
Sure.
And Gandolfer showed also that this membrane is in front of vitreous. Behind this, there is a vitreous. So this is part of the vitreous. So the ERM that we know, the idiopathic ERM that comes after complete PVD and then some remnants of hyalocyte to produce contracted ERM, which is this is centripetal traction. Here is centrifugal traction because this is continuous. So if you see the videos there, the studies Gandolfer to say maybe it doesn't do it, this is the exceptional. If you see ERM, is actually vitreal, and look at the periphery, you'll find sometimes beyond the vascular arcade, you see the point of extracentral. We also pull it up.
Any comment? So just to extend my question, so if the vitreous is detached, still you can have some membrane on the surface, and then if the vitreous is attached, you explained us, and what if the vitreous is detached?
The fully detached.
And there is a membrane on the surface of the edema. Do you have any strategy for that?
It's not strategy. You still have to check with the OCT, not only in the macula, not only in the macula.
In the periphery.
But check all the way until it, and then you find, sometimes you find 6 by 6 millimeters. All of this is ERM. And find there if there is a point of traction or not.
We did a work, we looked to that on fast OCT, and our working hypothesis was that if you have a lot of fold, probably this is a membrane that contributes, and if there is no fold, it's not contributing. But the surprise was that when there is fold, even when there is fold, when you treat them for the edema only by injecting whatever you inject, in many cases, not all cases, of course, but in a significant percentage of cases, the fold disappear. Like if the macula was a little bit soft, and then it's extended, and some fold disappear.
If you treat by anti-VEGF or steroids, you have anti-VEGF, you affect the blood vessels, the capillaries. So you closed the outflow. So these
Unfold.
waves
Disappear.
might disappear.
You have also seen.
And that is temporary.
Yes.
I think from my point of view of diagnostics and
Yeah.
follow-up of the patients, I see that whenever, according to the thickness of the membrane, if it is that thin membrane and there is no corrugation of the internal limiting membrane of the surface, and according to the tangential traction of the membrane, not even the vitro-membranous traction anteroposterior, it's the tangential traction which is reflected by the corrugation of the inner retinal surface. I think these all will account for the improvement of vision. And even if I will tell the patient that the membrane contributes to the macular edema, will respond to the injection, or the macular membrane will be more tough, that will be an obstacle to the improvement of the macular edema with the injection. I think
It worth being operated.
Yes.
Many of them, okay. Any comments or question from the audience? Okay, so is there any comments about the membrane? So we will move to our presentation, which are quite...
We can discuss afterwards.
We can discuss right now, which are actually not incompatible. I think it was half looking to the glass and it's half full or half empty. So I think we agree that you can have one of them, and the one after my slide was saying that you can have capillary occlusion and not edema. In others, you may have edema, but when you have edema, you always have some degree of capillary occlusion.
No.
Never, without no capillary occlusion, with no diabetic retinopathy.
No, yes, I think you can have edema without any capillary closure. That's clear, in my opinion. Because even the capillary closure in itself causes atrophy, not edema.
Okay.
It really may even mask some edema in the beginning by closure.
I see.
Therefore, I think edema is something that you can find very early in the diabetic retinal disease, but not sometimes in patients that don't progress at all.
You mean
The patients that have nothing else almost, no closure, very little neurodegeneration, and you have these guys with edema. It's not during the course of the disease. I'm talking about initial stage. But I think edema runs almost separately in a sense and then can combine. But I think all these factors, at the moment, I believe that they are happening separately in the retinas of edema.
I agree that sometimes it's separated, but in the most of the patients
Then you have
had-
advanced. If you have advanced retinopathy, you have all of them.
Yeah, I mean, it's not so usual to have a mild diabetic retinopathy and having a diabetic macular edema. Usually you are at the, you know,
Again,
it's a little more than mild.
when I'm talking about edema, I'm talking about 300 microns edema. You cannot, if sometimes you don't find it clinically. It's there because you have OCT measurement. And the OCT measurement shows that you have objective measurement of edema, and you say that you have central involved macular edema. But the patient go on a slit lamp, and, you know, probably in 10 persons, 10 doctors will say 5 yes, 5 no.
But do you agree that it's quite uncommon to have one of them without the other, completely without the other? Having no capillary occlusion, having edema, and having capillary occlusion very fast and never have any history of edema?
Yeah.
Is this the usual or quite unusual?
Sorry, the question is...
One without the other. Completely
Yes.
In the history of the patient.
Okay, my understanding at the moment, if you have very early stages, like 10 to 20, you know, a few, 1 microaneurysm, 2 microaneurysms, or a very early stage like 35, you may find clearly separation in these cases, and cases with edema and no capillary closure. Okay. However, if the guys that progress, that have 43, 47, or higher levels, they all of them have a large number of microaneurysms. When the microaneurysms start to happen, capillary closure is associated, because microaneurysms seem to be together. You know, microaneurysm turnover is an indicator of closure and vice versa, and of progression. And then you have the full picture of diabetic retinopathy. What I'm saying is...
at the beginning, you may have separation.
Exactly. And may not be the cause, the same cause playing a role.
So before I continue all my questions, I will ask the floor if they have questions or comments. Do you have any? If you have, just raise your hand and we will give you a mic. So, to continue to build on that, so do you think that it's because we are not able to detect one of them?
That could be. That clearly could be. Is the methods as much, you know, one thing I find all my life working on diabetic retinopathy, you initially were finding these things on retinal digests, in Indian ink injections, in retinas, in postmortem, in pieces of tissue. Now you see all these things in humans. And now for the first time you are bringing from the lab to the patient, and you can follow these changes very early. And this is, and the technique gives you so much. And if a better technique comes up, they will show much more. And therefore, it's a challenge, but I think that's the way to go.
That's true. And we talked here, the technique is evolving so quickly that
that's great.
We have to update all the time the data and our understanding.
OCT, I think in visualization of the foveal avascular zone and leveling of the separate different layers of the retina, superficial, deep, and even the intermediate, I think it's a great advance to visualize, because many patients, diabetic patients, coming with uncorrected visual acuity, and apparently in the fundus we don't see anything, and even by fluorescein, if 1 or 2 microaneurysms and they are not leaking, and the B-scan, there was no edema, but astonishing, when we used OCT-A, started to appear that, if I'm not that clear of the media, if there is minimal media opacity or diffusion of the dye by the posterior hyaloid, which obscures the clarity of the perifoveal capillaries, and all these things were abolished by the OCT-A being so dry and so sharp, which very minute, even the defect of the notching of the foveal avascular zone, which equals the ischemia, which equals the explaining the loss of vision in that patient.
So that leads, is there any comments or questions? So I have so many that if you don't have, I will still have some questions. That leads to another point we have time.
Go ahead.
2 minutes.
Go ahead.
So I finish with the two. This last question. So, you said that there is a correlation between capillary occlusion on OCT-A, that means in the posterior pole or in the macula,
Right.
and the diabetic retinopathy
Severity.
evaluated on the periphery.
Okay, no, I didn't
Is it
say.
what
I
you
didn't
said
say
or
that.
not?
No,
So
I
please
say
correct.
ETDRS grading is 7 fields and is mostly central. I really myself, again, and we don't have enough data, and there is some controversy in the literature regarding this issue. Again, the same problem with choroidal thickness. Periphery in a 60-year-old diabetes type 2 patient may not mean ischemia, may just mean atrophy. And therefore, I am not convinced that peripheral ischemia is so relevant as sometimes is painted in the fluorescein angiographies. I think it's more atrophy than if it is a blood disorder like microalbuminemia, multiple myelomas, changes in the sickle cell disease, then the periphery gives you a lot of information. In diabetes, I'm not convinced that it does. But I don't know.
Thank you. So I have two tasks still. One is to thank you all for
Thank
your
you very
excellent
much
presentation.
for
You can join your place.
Thank you.
And the second is to
I
ask.
quoted
Pleasure to
you
meet you.